the failure of the combined oral contraceptive pills in managing her symptoms, she was offered an endometrial biopsy in the office. But at the same time, during my counseling, I did make her aware that with hysteroscopy DNC, there's a higher chance of like her symptoms being managed like like after the procedure, rather than just that being done with the endometrial biopsy only, which would have only that diagnostic value. But with a hysteroscopy DNC, there's uh, a diagnostic as well as a therapeutic benefit to it, and it will represent more, and it will provide more representation of the endometrium, as an endometrial biopsy only represents 4% of the endometrial cavity, or of the total endometrial sample.
Okay. So you're saying the endometrial biopsy um is
It's not a
not as
treatment. It's not a
okay.
treatment. It's only for diagnostic purposes.
Correct. But you're saying the endometrial biopsy is not as sensitive as the
It is
DNC
sensitive.
for
The
rule out malignancy.
the sensitivity of an in-office endometrial biopsy can be as high as 80 to 90%. However, with performing a hysteroscopy DNC and with sampling that will provide an even higher sensitivity than that.
Okay. 25, you put a um, eternal implant in the patient. Um, what's the dosing for the eternal implant usually?
I'm not actually entirely sure of that. I'll need to look it up. But uh, but uh, but this patient saw me, and she had it in place.
Oh, she already has it.
Excuse me. Yes, she already had it in place when she saw me. Correct.
Okay, got it. Patient 30. So this patient had a ruptured ectopic, um, and you had a laparoscopy with salpingectomy, and there's no villi identified. So how are you sure that this was a ectopic pregnancy?
So, the patient, when she came to the emergency department, she was complaining of acute abdominal pain. She also had a positive pregnancy test that was done via serum HCG, and that was more than 3,500 units, and her clinical presentation on physical exam was very significant uh, for rebound tenderness, guarding rigidity, as well as the pelvic imaging that was done showed uh, an adnexal mass that was highly suggestive of an ectopic pregnancy. And my findings during her surgery were 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 also highly suggestive of an ectopic pregnancy, given that her fallopian tube was ruptured, and it was bleeding, and it needed to be removed. Uh, there was a significant amount of hemoperitoneum that was seen during the surgery, and that was removed from the patient's abdomen, and there is and it is and it is most likely that the ectopic pregnancy was removed or suctioned out of the abdomen during the evacuation of the hemoperitoneum, and that wasn't sent to pathology. Yes, so that is the most likely scenario of what happened is is that the patient had a tubal abortion, or the pregnancy was present amongst among the hemoperitoneum that was suctioned at the time of the surgery.
So did you follow the patient with later
Yes,
ACG afterwards?
I saw the patient in the office 2 weeks after her surgery, and her urine pregnancy test was negative in the office.
Okay. Patient 32. Uh, chronic pelvic pain, bilateral ovarian cyst. Um, what are the chance of a teratoma present bilaterally?
I believe the risk can be as high as 20%.
Okay. Is there any possibility for a benign teratoma to turn into malignancy?
Yes, of course. And I think that risk is between 3 and 5%.
Okay. Patient patient 36. Let's see. So this patient seems to have a lot of adhesions. What do you think caused the adhesions?
I believe the adhesions, based on based on the intraoperative findings at the time of her surgery, I have a high suspicion of the patient having endometriosis. I did perform an ovarian cystectomy, and it didn't show any signs of endometrial disease. However, I however, I did not perform peritoneal biopsies of during her surgery, and it would have been helpful to sample the peritoneum in this patient, especially if there was a suspicion of endometriotic lesions, such as gunpowder lesions, uh, nodules, clear nodules or cysts, uh, the findings, the intraoperative findings that may also be highly suggestive of endometriosis are Allen-Masters windows, which are peritoneal defects in the peritoneum. Yeah,
Okay. Is there a way to categorize the severity of endometriosis?
I believe there is a staging system, a surgical staging system for it, but I'm not familiar with it, and I'll need to look it up.
Okay. And let's see, patient is started on OCP. Okay. Let's say this patient is a little bit older and continues to have chronic pelvic pain. At that time, is there anything else you can offer her other than just OCPs?
Yes, she can be offered for management of symptoms of pain, uh, and with a clinical diagnosis of endometriosis, the patient can be offered GnRH antagonists, which is elagolix, and that has been shown to help manage the symptoms of endometriosis for over. It has been shown to provide symptom relief for pain in up to 80% of patients within 12 months of follow-up. And also, these patients can be started on aromatase inhibitors, which have been shown to help manage the symptoms of pain associated with endometriosis. However, it does have a very heavy side effect profile, and also nonsteroidal anti-inflammatories, if not tried before birth control pills, do have a role as well.
Okay. And how long can you keep the patient on GnRH and antagonists?
I believe 1 year is the maximum duration approved by the FDA
Okay.
for that indication.
What if patient's still having pain?
There are also alternative management options such as sacral neuromodulation and um, and I believe that is one of the options that can be offered to the patient, and surgical removal of the endometrial of the endometriosis lesions from the pelvis. Can be also can be also offered to the patient with failure of sacral neuromodulation.
What if the patient requests a hysterectomy?
As long as the patient has completed childbearing. I'm not sure if it's the same, like in the same scenario, she will be also a nulled patient, but as long as the patient doesn't desire future fertility or to preserve her uterus, I would counsel her that surgical man management options are associated with a very high rate of symptom relief. And I would counsel her as well regarding the risk of recurrence if 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 the hysterectomy is performed without BSO at the time as well.
You said high rate of recurrence?
Recurrence of symptoms, yes.
Okay. Do you know the percentage?
I am not sure. I will need to look that up.
Okay. All right. Let's keep going. Patient 40. Okay. So patient 43, it seems like you gave her some blood products. Um, let's say the patient after the transfusion develops a fever. Um, what are some of the causes for what is your differential diagnosis? Fever
So
after
in a
transfusion.
patient receiving a blood transfusion who experiences a febrile episode, my differential would include a febrile transfusion reaction, uh, a hemolytic transfusion reaction, or ABO in or ABO in incompatibility, or also I would consider the transfusion associated lung injury as one of the causes of that.
Okay. And let's say she has the febrile non-hemolytic transfusion reaction. What would you do in that instance?
I would stop the blood transfusion, and I would also manage the patient's symptoms. So I would administer Tylenol or nonsteroidal anti-inflammatory medications to manage the patient's symptoms. I would monitor her vital signs uh, and and her urine output as well. And usually these symptoms resolve with the discontinuation of the transfusion and the management of symptoms.
Would you restart the transfusion if she's symptoms improved?
No, I would send the blood unit that caused the transfusion reaction back to the blood bank, and I would inform them that the patient had an adverse reaction to the blood transfusion, and the patient should then be typed and crossed for new blood transfusion products, and we may attempt a transfusion again once the patient has been typed and crossed from the very beginning, like the process repeated from the start. And I would also consider this to be a near miss event, and I would involve the hospital staff uh, and consider writing a safety report regarding this incident.
Okay, so this is for the febrile non-hemolytic transfusion reaction that you will be doing this.
Uh, if it is a febrile non hemolytic reaction, I may consider doing that.
Okay. All right. Let's continue. 51. Let's see. Hold on. Let me get to it. 51. Uh. Okay. So what would be your let's say this patient comes into the hospital with acute vaginal bleeding. How would you manage this patient inpatient?
So I would evaluate the patient by performing a history and a physical examination. I would evaluate the patient's vital signs, clinical symptoms, if she's having, how much bleeding she's having, how many, is she passing clots, is it associated with pain, how many pads is she changing, is she symptomatic with symptoms of hypoperfusion or orthos orthostasis, such as dizziness, lightheadedness, shortness of breath, palpitations. I would inquire to see if the patient had a prior blood transfusion and how heavy her periods have been since menarche. I would also inquire to see if she has any history of postpartum hemorrhage, easy bruising, bleeding gums, or anything that would be suggestive of a high risk uh, of coagulopathy. And then I would proceed with performing a physical exam to perform a speculum exam to visualize how much bleeding I can see coming out of the cervix. I would also make sure the patient has no lesions on the cervix itself, and I would also perform a bimanual exam to evaluate the size and the shape and the contour of the uterus, and also to evaluate the size and the mobility of the uterus with that. And then I would proceed with performing lab evaluation. I would order a CBC, a type and screen, a chemistry panel, a TSH, A1C, prolactin, and also, depending on the results of the hemoglobin, I would consider typing and crossing the patient if her hemoglobin is low, or if she's symptomatic with symptoms of uh, of sorry of orthostasis and also showing vital instability. I would then proceed with pelvic pelvic imaging to rule out any structural causes that may be leading to these patient symptoms, such as fibroids, adenomyosis, or polyps.
Will you give her
And
any medication if she's actively
Yes,
bleeding?
yes, assuming there are no contraindications, I would start her on IV conjugated equine estrogen, 25 milligrams Q4 to 6 hours for 48 hours, or until the bleeding subsides. And during that time, I I would also start the patient on an antiemetic to manage the associated side effects of that are associated with the IV estrogen, with the management of the acute bleeding episode. I would then start her on a birth control pill taper, where she takes uh, high dose combined oral contraceptive pills 3 times a day for 10 days, and then decrease it over the next 2 weeks until she's taking one pill a day daily.
So what are the contraindications?
The contraindications to IV conjugated or to
IV
to
Premarin. What are the contraindications?
yes, those would include personal history of of breast cancer, hypertension requiring medications, smoking, uh, personal history, or sorry, not personal history, uh, mm, active or recent DVT or PE, severe liver damage or liver disease, allergy uh, uh, to 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 estrogen, or and that's all I can think of at this time.
Okay.
Or severe dyslipidemia, or lipid abnormality.
Okay. So you're telling me that you would get a lipid panel before you start this patient who's actively bleeding on
If
Premarin?
she reports a history of that to me, I would consider ordering that. But with the absence of history, or with the absence of other risk factors, uh, such as such as such as such as obesity, or signs and symptoms of metabolic syndrome, I wouldn't assume the patient has a lipid abnormality.
Okay. Would it be would the indications be any different from someone who you're just starting regular oral contraceptives on?
They wouldn't.
Okay. Um, let's say she does have a contraindication to Premarin. What will be your next go-to?
I would try a medication that contains progesterone only.
Which will be?
I can try I can try oral medroxy progesterone acetate, 10 milligrams 3 times a day for 10 to 14 days. I could also consider using oral uh, mm, magistrol acetate, 20 to 40 milligrams 2 times a day. Uh, I would I could also consider intramuscular Depo-Provera 150 milligrams once Q3 months. And there's a role also, but not for the management of acute bleeding, probably, but there's a role for the more gestural intrauterine device to manage long-term symptoms of abnormal uterine bleeding.
Okay. Patient 52. Uh, so this patient had a urology consultation. What was the reason for the urology consultation?
The patient presented back to the hospital 3 days after a, a, a robotic assisted laparoscopic hysterectomy that was complicated with a serosal bowel injury with a fever. So the patient was admitted and she was started on IV antibiotics as her physical exam was highly suggestive of a UTI. However, given that the patient was also complaining of some flank pain and that her surgery was complicated, there was a high suspicion of injury to the ureter, and she was kept on IV antibiotics for 48 hours, but her symptoms were still persistent, and she was still having some febrile episodes, and due to the persistence of her symptoms on the IV antibiotics, a, a urology consult was then called to evaluate for a possible injury to the ureter that is related to her complicated hysterectomy 3 days or 4 days prior.
And how is this serosal injury identified?
It was identified by me during the hysterectomy.
Okay, and then it was subsequently repaired,
Yes,
or
I then called
during the case.
during the case. Yes, while 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 the patient was still under anesthesia.
I see. Okay. Um, let's see. Patient 53. This patient has hepatitis B. Um, let's say you're doing her surgery, um, and you
This
gotta.
is this is the last question. Okay.
Okay. Let's say you're
Yeah.
doing a surgery and then you got a needle prick. What
Oh,
happens to you? What would you do?
I would. I would. Oh man. Uh, I would perform. I would inform the patient of the complication that I that happened, and then and then I would also notify the hospital staff and follow the hospital protocol in case of a needle stick injury with a positive uh, bloodborne infection present in a patient. I don't know the exact steps of the protocol or how it will develop, but I would uh, I would want to receive the immunoglobulin to hepatitis B in a series dose, and I would also uh, uh, notify my physician and my colleagues and my and my spouse of the potential of that infection as well.
Okay. Not bad
That's
actually
just yes.
for someone
Yeah, I don't
something that you
know.
don't know. Not bad, not bad.
Yeah, I never thought about this actually
Right?
because
Yeah.
you know what happens, but usually patients are not infected when it happens, so whatever.
Yeah. Yeah. So,
So what do you think I do, Professor?
you did
No.
great. You passed.
Oh, good. Thank
All
God.
right. Oh, did you have to go somewhere? Sorry, I didn't know you were.
No. Just because it's like 30 minutes, and then and then I still didn't have dinner and stuff. So
Oh,
and
okay, okay. Yeah, yeah.
yeah,
No
but
problem.
yeah, so we can do like 30 and 30, and then like on a different day we can do something longer or like
Yeah, yeah,
saying
yeah. No
whatever.
problem. Yeah. All right, so let's go through it real quick. Let's see. 90, 19. Okay, 19. I mean, what you said was fine. I was just wondering, do you? So for the therapeutic dilation curettage being therapeutic, I don't
Yeah,
know if that's like a
evidence
real,
based
yeah,
is a
I don't know if
thing.
that's like a real thing.
Yeah,
I have to look into that.
yeah.
But yeah. And then
Okay, but no, but what would you say like if they like ask you like like why didn't you do a biopsy instead?
I mean, you try to offer a biopsy and patient refuse. You could always say like, oh,
Mm,
it's good for detecting malignancy. However, if there's a focal lesion,
right.
then the DNC might be better, or hysteroscopy DNC might be better at identifying pathology of the
Nice.
focal lesion,
Yeah.
right? But
Yeah.
if it's a generalized, you know, pathology, then the endometrial biopsy is just as good as a DNC. So you can
Got it.
spin it that way.
Uh,
But I don't know
nice.
about the therapeutic part. I have to double check on that.
Yeah, that sounds like a better answer either way. So yeah, that's fine.
Yeah.
Okay.
And then is it patient? Oh, the next one is actually 60 milligrams of eternal.
60. Okay.
Yeah, 68. 68.
68
Yeah. Uh,
milligrams, not micrograms.
I believe it's milligram. Yeah.
Sure.
And then patient 30. Yeah, what you said is fine about the, as long as you have a reason
Hmm.
for the topic that's not identified. And then the malignancy rate is
Yeah, I didn't know it
yeah, it's
honestly.
actually
I
you're
made it up.
really close. It's actually 1 to 2%.
Hmm.
So, and then the chance of finding a bilateral teratoma is about 20%, 15 to 20%. So you're pretty close.
Cool.
Yeah.
Cool.
And then 36 was the endometriosis. So the staging system is 1 to 4, and it does not correlate with patient symptoms. So and then I have to look up the aromatase inhibitor about for the treatment of endometriosis.
I
Do you
think it
know?
was in the I think it was in the bulletin, but that was
Yeah.
in residency. Like I didn't read it for a while, and I know you can do like Lupron too, but in like preparation for surgery. But
Right, right. It's
yeah,
a very
yeah,
short term, and
right.
the antagonist is actually good for 2 years if you do ABAC,
2 years,
add
sure.
ADBAC therapy. So it's good for 2 years. Um, um, uh, so the one I use is myfembree, and it's
My
actually
family, yeah.
yeah, it's a little bit newer, but um, it has the
That's for bleeding though, right? Or is it for pain as well?
it's approved for fibroids and for heavy bleeding and also
Heavy bleeding.
endometriosis. Yeah.
Oh, cool.
Mm-hmm. 42, the transfusion reaction, uh, the non-hemolytic transfusion reaction, I don't know if it's, like, I don't think you need to report and all that stuff.
Yeah, yeah, yeah.
Yeah.
That's
I think
fine. But
because
I
that,
just didn't want to like contradict myself or whatever.
yeah,
Yeah.
because those are the non-life-threatening one. For the acute hemolytic transfusion reaction, which is the same as is caused by ABO incompatibility, that one you
Mm,
definitely have to
report that.
report. And then the
Yeah.
one where you have to like restrict the product is the trolley, the lung one.
Hmm. Hmm.
So the donor has to be identified and the product has to be restricted. Um,
Oh, like if he gave any other products, they
yeah,
need to be
to other
found and
people.
like, wow,
Hmm.
wow. And is that can that cause a fever or
Yeah, that's the
yeah,
three.
right?
The
Yeah.
ones you said is actually correct. The three that causes
No, cool,
fever. It's
cool.
trolley and then the ABO incompatibility and the non-hemolytic. Um,
And will like hemolysis cause a fever too? Like, can it,
hmm
it can
Yeah,
cause? Yeah, it can.
it can.
Okay,
Uh-huh.
okay,
Yeah,
cool.
and flank pain, like
Hmm.
acute kidney injuries and all that good stuff.
Good stuff. Yes, sir.
Yeah. And then the treatment for acute uterine bleeding, the contraindications actually different for acute
Mm.
treatment, because you don't. So like if the patient has hypertension, uterine you can still give the uterine not the uterine the Premarin.
Primary. Yeah.
Yeah. So anything less than 4 weeks, um, the only contraindication for those are like the cancer, history of DVT or active DVT, or
Hmm.
active liver dysfunction or liver
Disease. Yeah,
disease. So
but not the hypertension. Okay.
no,
And
hypertension you can
smoking.
still give, smoking you can still give. Um, so
Mm,
for a
mm,
short for like a short
Migraines with
period.
aura.
Yeah.
You
So
can give with
the only
migraines with aura. Yeah.
contraindication is the one the few that I
That,
mentioned.
yeah.
Yeah, breast
VTE and the
cancer,
cancer,
DVT, and then liver.
liver.
Yeah.
Oh, lipids are not ones, right? Yeah,
No.
because I felt you were just like messing with me. Okay. Yeah. Yeah.
Yeah. Uh, what else? The
I think it's
urology.
for yeah, for
Sorry.
like menopause. The lipids are for like menopause, like when you start like HRT, like they can be a contraindication.
Yeah, so for
But I guess yeah.
HRT, you're supposed to get a cardiovascular risk profile,
A, a calculator.
which
Yeah.
includes the lipid panels.
Right, right,
Right.
right.
Yeah,
Cool.
and then you're supposed to use the Gale model for the breast as well to see the breast cancer. There's like a
Cool.
cutoff. Um, I forget the
Cool.
numbers, but
Yeah, me too, all the time. So many
yeah,
numbers, man.
I know. Um, and then the rheology one, that's fine. I was just wondering because there's like a messy situation there.
Yeah, yeah, yeah.
Uh-huh.
No, she did good, but like we were worried because she was still having fevers. I'm like, oh, geez, does she have like a ureteric injury? And she was like a complainer. Like she complained about everything. So
Okay.
yeah, like if she has any very little pain, she tells you, oh yeah, she has that little pain. So
Uh-huh.
she doesn't let anything go.
Right. That's why she gets
Right.
all the tests in the world.
Everything in the world.
Uh-huh.
Yes, dude, she got 3 CTs in the hospital because I swear, man, this lady was it drove
uh,
me crazy,
one
bro.
of
Yeah,
those people.
one of those people. Yeah.
Uh-huh. And then the needle prick. So the first thing you check is their status, if they're Hep B. Well, you said that she's Hep B positive, so she's definitely Hep B positive.
Right.
But then it also depends on if you had your vaccination already. Most people already do. So most of the time you
Hmm.
just need to check to see if your anti-hepatitis B surface antibody is high enough. If it's high, then you don't need to do anything. I think it's like
Mm.
10 milli international units per something.
Mm.
But if it's low or if you don't know, then you need to get your Hep B IG and then your 3 sets of vaccination.
Got it.
Yeah,
Okay.
and then you
And do you, sorry, like, is there a role for like a viral load with like hepatitis B? No, right?
not for the patient. You don't check that.
Right. Okay.
You just check
Yeah.
their surface antigen positive, and then you can also check their hepatitis E antigen, because
Mm-hmm.
they're more infectious if they have that.
Mm-hmm.
And then you just get all your vaccines and your Hep B IG.
Got it.
Yeah. All right. You want to do mine real quick?
Good. Do you want to do
Uh,
GYN or office?
whatever you want to do. I don't care.
Yeah, we can do office. Let's do
Okay.
that.
Gotta know everything anyways.
Yeah. What do you call it? Ray. Do you like that lady from like yesterday? The one she speaks too quickly, I feel. The Millie one, the not the guy from today. The guy from today was great. I love him, but
Yeah.
the ladies,
Oh, yeah,
she gets
she
on.
she
Yeah,
I mean, it's okay. She's very thorough, I guess.
yeah.
But I feel like I mean, she just basically reads off of up to date. Uh,
Right, right.
yeah.
And like she speaks really quickly, yeah, and I'm like, "Oh no, this is up to date." Like, what? Come on, get like say
Yeah.
something different, you know?
Yeah.
Oh, oh, but that guy from today, I really like him actually. He's
Yeah,
very cool.
I
But
think he's MFM,
he's
so
MFM, yes.
yeah,
I looked him
so
up.
that's why
I
it's
looked
why
him
he's
up.
good. So
Yeah,
like
but
and
like it's a shame. Like it's a shame that he does OB only. Honestly,
I
I
mean, yeah,
wish
cause
we
he's
had people like
MFM,
him doing
so
GYN. Yeah.
I rather
No, but I mean, yeah.
I rather him stick to what he knows, you know?
Right, right. All right, cool. All right, case number one, doctor. In your
Oh.
office, you have a well woman exam. Um, and her DEXA score was -2, and she's a 65-year-old. So, what is a DEXA score? How do you get it? And what is a score of -2 indicative of?
So a DEXA scan is a scan that you can provide to the patient to see if they're at increased risk for fracture, or if their bones are if they have osteoporosis. So a T-score less than -2.5 is considered osteoporosis, and then a score between 2.5 and -1.5 is considered low bone mass. Um, so for this patient, she had a score of -2, so she does not meet the definition of osteoporosis. In these patients, you can use a FRAC score to see if they meet the requirement to start osteoporosis, I guess, therapy, medical therapy.
What is the definition of like osteoporosis?
A T-score minus 2.5.
Oh, okay. And what is a T score?
A T-score is the patient's bone density is I guess 2.5 standard deviation from compared to someone who's a healthy uh, to the healthy female. So it compares the patient's bone density to someone who's healthy um, at like 20, age 25.
Okay. Is that the only score that you get from a DEXA scan, or is that something else that you see there on the report?
You do get a Z-score as well. However, the Z score is not commonly used to calculate if the patient needs therapy or not.
What's a Z score?
A Z-score is comparing the patient's bone density to someone who's of her own age.
Okay. Okay. All right. And what else did I want to ask you, doctor? Can you hear me still?
Yes.
Okay, good. And what is a frax? What is that?
A frax is a calculator that we can use to it serves two purposes. One is to see if the patient needs to be on therapy after the T-score is calculated and it's less than 2.5, but in the low bone mass range.
Mhm.
The other way to use frax is to um, see is if the patient is uh, menopausal, however, is not 65 yet. You can use the frax score to calculate their risks of fracture to see if she is a candidate for a DEXA scan.
Okay. And and what situation would you start treating someone? Like what frac score would you use, or what in the patient's history would you use to treat someone, even with a score of even with with like a T score that's not less than 2.5 yet?
Yeah, so if the patient had a fracture, a prior history of fractures, then you would consider start treating the patient. Or if the frax score, um, I believe uh, the it's the osteoporotic fracture risk is greater than 20%, and if a major hip fracture risk of greater than 3%, that you would treat this patient.
Okay, sounds good. And how would you treat them?
You would start them on
What are your
oral.
options? Yeah.
Yeah, normally you start them on bisphosphonate. Um, there are other medications that you could use. However, um, I do not personally start them on any of them. So I would refer her to a endocrinologist if they are not if they're contraindicated if they have contraindications to taking bisphosphonates.
And what are some of the precautions? Like, what's the dosage of bisphosphonates that you prescribed, uh, and like, what are some of the side effects or the precautions that you tell patients about when they start bisphosphonates? And what are some of the contraindications to starting bisphosphonate?
Uh, so the dosing I will have to look up to make sure I give the patient the correct dosing. The contraindications will include if patient has peptic ulcer disease, if the patient cannot sit upright for 30 minutes after taking the medication, if she had renal a disease, um, uh, I think that's the main contraindications.
Okay, sounds good. Let's go to, let me see here. You had a chlamydia. Okay. You said in case number two, the patient had a chlamydia infection and the rescreen was negative. When do you perform that rescreen test? Like how long after treatment?
Rescreen is usually performed 3 months after the treatment.
Okay, and that is different from a test of cure, correct?
Yes.
And how soon would you perform a test of cure, and like what are some of the circumstances that you would perform it?
Uh, Test of cure will be usually I do them in pregnancy, and usually it's done uh, about one month after the treatment.
Okay, all right. Uh, then we have, I think we spoke about this patient metabolic syndrome before. Oh,
Yeah.
and then okay, all right, that's good. That's good. Not bad. All right. Then labial ulcer. Let me see here. 90-year-old. Wow. Endometriosis. Wow. Yeah, I don't know like much about menopausal vulvar lesions and vein and stuff, but case number six, man, they can ask you a lot of questions on that. Okay, so
Oh
just
yeah, that lady.
yeah.
The other
What did
lady,
she
what
have?
was her name? She
I don't want to
she
know her name, man. Don't tell me her name, bro. I'm
no no no
just kidding.
that
Yeah.
she uh she went through the vulva
Oh yeah,
sclerosis,
yeah, yeah.
lichen
Oh yeah,
sclerosis, and
yeah.
that was
She
pretty
was.
helpful.
That was very. Yeah, this lady was really good too. She was very thorough. Yeah,
Yeah, I like her.
I liked her a lot too. All right, let's see. Case number seven: abnormal uterine bleeding. Doctor, what is the definition of abnormal uterine bleeding?
Abnormal uterine bleeding is any bleeding outside of your normal cyclic periods, which is um, less than uh, 21 days or greater than 35 days, and the amount is greater than 80 cc's of 80 cc's daily. However, it's hard for patient to quantify that, so usually we just say it's the uh, more than what the patient is used to. Um,
Mhm,
I
mhm.
think that's it.
Do you know the numbers? Do you know like what percentage of patient with like normal bleeding will say that they have heavy bleeding, and what percentage of patients with like heavy bleeding will think that they have normal bleeding?
Oh, I don't. Do you know?
Yeah. Yeah, yeah. I'll tell you when we like
Oh,
review
okay,
or
okay.
when I fill it up. Yeah, yeah. Yeah, that's cool. All right.
Yeah, yeah.
And like what are some of the causes of like abnormal uterine bleeding?
So usually I use the uh acronym POM-COHN. Um, so for structural abnormalities, it's polyps, adenomyosis, leiomyoma, and malignancy or hyperplasia. And then for what are those called? The other side,
Functional?
non-structural,
Yeah. No.
functional uh, causes will be coagulopathy, uh, ovulatory, endometrial, iatrogenic, and non-otherwise specified.
Okay. And let's say a patient has a fibroid. Let's say this patient, she's how old? She's 45 years old. Let's say she has like many fibroids in the uterus. Is there a classification system that you use to like classify these fibroids, or to like anything
Yeah.
that you use in your practice? Yeah.
Yeah, so the fibers can be categorized depending on their location in the uterus. Um, a 0 fibroid would be a submucosal pedunculated fibroid. Uh, uh, class 1 to 3 will be a submucosal fibroid, but part of it will be in the myometrium. And then 4 and 5 is a endometrial fibroid, or is it myometrial fibroid, and then 6 and 7 will be a,
Doctor, what's the name of that classification system? What,
I
who,
believe it's the white class. That was the white classification.
the FIGO
Oh,
classification?
the
Okay.
FIGO, correct, correct.
Yeah. Okay, cool. And how, like, let's say you have a patient with her hemoglobin's 9.8, she's having a lot of bleeding. She's saying it's taking like a big toll in her life, and she wants to be treated. How would you counsel her about her treatment options for like
S-
fibroids?
Right. So for fibroids, for bleeding, I believe there is uh, for uh, for main treatment. You can do um, oral contraceptives. You can do IUDs. You can use progestins. You can use GnRH and antagonists or agonists.
Do you ever
Um,
use uh, uh, mifepristone or ulipristal in your practice, doctor?
uh, Not for fibroids. Well,
Okay.
mifeprostone we don't have access to. It's not readily
Mhm.
available, so we rarely use them. And ulipristal is
What is mifepristone? How does it work? What's its mechanism of action?
mifepristone is a anti-progesterone. I don't know if to, is it anti-progesterone or anti-estrogen?
Progesterone. It's
Okay,
a
yeah,
selective. It's a
yeah.
selective
Selective
receptor
progestin,
modulator.
receptor modulator, and so
Cool.
is ulipristal.
Ulipristal. And what? And is there like a side effect that's like associated with ulipristal that you know of that is severe from its use, from its regular use?
Uh, Not that I know of. And
Sure. Okay.
maybe like a um anti. I mean, it's an anti-progestin, so I would think you have maybe hot flashes. I don't know.
Yeah. Okay.
Oh,
That's
we'll
fine.
talk about it.
We'll talk about it. All right. And then you have a patient here. Patient number 17. She had a left vulvar mass, a 60-year-old left vulvar mass. She has and then you did a IND with a word catheter placement. Can you walk me through this procedure, doctor? How did you do it? How did you perform it? Yeah.
Yeah, so the patient will be laying in a supine lothotomy position. The left labia and the mass will be
Do you consent to your patient first, doctor?
okay. Yes. The patient
Okay.
is
Sorry, I just have to be a
no,
little
no, no.
annoying. Yeah.
The patient is consented, and then the patient is in position. The area is cleaned with betadine, and a small incision is made in the inner uh, vaginal aspect of the Bartholin cyst to drain to drain the abscess, or it's not an abscess, it's just a cyst. After the draining of the
Really?
um,
Stop. Sorry about that. Keep going. Yeah.
After draining of the cyst, then a word catheter will be placed into the small opening, and then a about 3 cc's of normal saline will be injected into the word catheter to keep it in place, and the tail will be placed into the vaginal canal to keep it out of
And how long do you keep that in for, doctor? And like, why do you do it? What's the value of it?
Yeah, usually it's kept in place for 4 to 6 weeks. However, sometimes the catheter can fall out before that. The reason for the catheter is to uh, prevent closing of the lesion, the opening, so that it can reepithelialize and create a new opening, so the cyst can drain on its own.
Okay, very good. And let's say the patient came back with another one. Would you do another IND with another word catheter, or what? Like, how would you counsel her patient about her treatment options? Also, this patient is 60 years old. Would you have done anything else besides just an IUD and a word catheter placement for this patient?
Yeah, so this patient, I did do a biopsy of the cyst wall for since she is at increased risk for malignancy. Um, and then if she had a recurrence of the cyst, I would recommend a possible I would recommend marsupialization procedure. Um, and then or a possible even a excision of the cyst.
What are some of the complications that can happen with like an excision? Like the surgical challenges. Is it like an easy procedure, or
Yeah,
like have you done it before?
yeah, I have performed the procedure before. I understand that sometimes because of the location of the Bartholin cyst, we can encounter heavy venous bleeding because of the venous plexus around the area.
Mm.
So when I do the procedure, I make sure that I am very careful, and I try to stay very close to the cyst when I dissect the cyst, and
Mm.
so as to not to disturb any surrounding structures.
What is the blood supply? What is the blood vessel that feeds the Bartholin's?
I believe it's
Mm.
the pudendal artery.
Good, very good. And what is that a branch of?
It's a branch of I want to say the external iliac,
External iliac?
or is it the internal?
Yeah, the internal
Okay,
iliac.
the internal.
Which division? The anterior or the
The
posterior division
anterior,
of the
the
internal iliac?
anterior division of the internal.
The anterior division. What are the other branches that come out of the anterior division of the internal iliac? And oh no, seriously, you don't.
Okay, so let's see. So you have the vaginal,
Mhm,
the pudendal,
mhm.
the is it like a nine branches?
Yeah, like yeah, something
Um,
like that. Yeah,
yeah, vaginal, uterine, uh,
uterine. There you go. There you
uh-huh,
go.
bladder,
Yep.
um, basically anything in the pelvis. What else is in the pelvis?
Okay.
Ovarian?
Maybe. No,
I have
no,
to
that's
look it up.
from the aorta. Yeah, that's cool. That's cool. All right, cool. And then, all right, and then we have here postcoital cystitis, blisters. All right, doctor. There's a patient here, patient 23. She had vaginal burning and blisters. And then you had a HSV2 positive via STI screen. When you say how did you diagnose her with HSV2 positive?
What number is this?
23. Is it
20.
23? All right, let me
Oh,
see.
23, yes.
Yeah.
So this patient actually presented with the blisters. So to diagnose this patient, I performed a vag um I scraped some of the um opening of the vesicle. I opened up a vesicle and I used a swab to swab the vesicle and send it to the lab for a PCR
Okay.
amplification test.
And did you do anything else besides that, doctor, or just the swab?
Um, and then I did STD screening for this patient as well. And then
Did you?
she was concurrently started on acyclovir.
Okay. Did you do any blood work?
Not for this patient.
Okay. And what is and what is the dose of the acyclovir that you started her on?
She was started on 400 milligram PO TID for 10 days.
And did you counsel her like about the risk of recurrence? What's the chances of her getting a recurrence
Um,
with like
I counseled her that the herpes virus, the medication is not curative. The herpes virus does stay in her body for the rest of her life. And
Mhm.
there is a chance for recurrence when patient is uh, uh, in stress, if her immune system is compromised. I do not I do not remember the exact percentage of
Sure,
recurrence.
sure. And where does the herpes simplex virus reside in the body, or like where is it dormant?
I believe the nerve roots, the whatever the
Sure,
um yeah the nerve roots.
sure. Okay, okay. Sounds good. And then this lady, 35, multiple leiomyoma. That's not bad. That's not bad. Okay. All right. One last question. Uh, hmm, hmm. All right. No, let's skip that. It says, hmm. All right, doctor. You have a patient in case 33. She's an 81-year-old lady with like a pelvic organ prolapse and urinary
Wait, what
retention.
number?
34,
Oh,
34.
34. Okay. Okay.
Did
Yeah.
I say?
You said
What
33.
did I say? Oh no, 34. So she has pelvic organ prolapse. How do you diagnose, or like, is there like a tool that you use in your practice to like determine the severity of pelvic organ prolapse in your practice?
Yes, I use the PopQ system.
What is the PopQ system?
The PopQ system is a systematic way to determine the stage of the prolapse, and also um, it gives us some detailed information about the location of some of the structures in of the pelvic organ in relationship to the introitus.
Sure. Okay. Very good. And I saw that she had a pessary. What are some of the other treatment options for her? Uh, Yeah. What are some of the other treatment options for?
Yeah, so for her, the treatment option would be pelvic floor exercises, and pessary, and a surgical treatment, including um, uterosacral suspension, sacral ligament suspension, um, and sacrocolpopexy.
What is what is what is a Lefort procedure, doctor? Are you familiar with that?
Which one?
Lefort or
Oh, a LaFour, yes. So a LaFour is a ablative procedure where basically the vaginal mucosa is opened up and sutured together from anterior to posterior, leaving a small opening on the side. This is for mainly for patients who are older, who has risk factors for long and complicated surgeries, and also if they have no interest in sexual relations.
no interest? Okay, nice. Yeah, cool. Nice work, man. Cool. We're done. All right. All right.
All
How
right.
do you dude? Uh, 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 dude, you're a lot. I think. I think I feel you did a lot better than like the last time I we spoke. I think you've been practicing a lot, so that's that's
Probably.
very good. Nice,
Yeah, I
yeah,
mean,
very
I don't
good.
have much time left, so.
Yeah, nice, dude. No, that's very good. All right. So, when I was asking you about the definition of like osteoporosis, there's like something you can say. It's like a systemic skeletal disease characterized by architectural deterioration of the bone. You know.
Wow, that sounds very
Yeah.
technical. Yes,
Yeah, but like whatever.
much better.
Like I'm not sure if and like yeah, but like a T score of less like but like you can still like treat someone with a T score of like not 2.5, I guess,
Right, based on the
by
facts.
district's
Yeah.
criteria. Yeah, exactly. But yeah, it's fine. And then
Was
the
it is it two
bisphosphonates,
1.5 or one 1? Is it 2.5 to 1? That's low bone mass
I
or
think so. 2.5 to 1, yeah,
to 1?
for
Okay.
the low bone mass. And then 0 to less than 1. I just went over this like last night. And
Oh, you
then a
did.
T score, yeah, and then a T score is the only it is the only score that is used to like to, to, to like diagnose like osteoporosis, and it is the bone mineral density that is compared to the mean bone mineral density of young healthy controls, so like
Mm-hmm.
25 years like you said. And then the z scored is compared to like age 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 matched age matched women. Okay.
Right. Okay.
So yeah. And then something I thought was interesting is that 71% of fractures due due to osteoporosis uh, in patients more than 50 happen in women. So that's why it's important to
Mm.
70%. Yeah, so it's like a
Yeah, nice.
uh, large percentage. And then what do you call it? And then bisphosphonates, some of the common contraindications. I think you said all the things about the fracks and stuff are really good. I think with the fracks of less than 20, like you said, for the long bones, or 3% for the hip you treat. But there was something where that was like 9.8. I'm not sure what was that.
That's the one you use to see if you want to do a T
A
score.
fracks.
No, no, no. You use
Oh,
the fracs
oh no.
to see if you want to do a DEXA scan. So
Oh,
so if
okay.
they're
And
like,
do you
let's
use
say if
it
they're
for like patients with like risk factors and stuff, like smokers, low
yeah,
BMI?
yeah, yeah. So if they're like
Okay,
50, like postmenopausal, but they're not 65 yet, you can use the
got
FRAX
it.
score to calculate and then it's like 8.4 actually.
8.0. Oh,
They lowered
it's
it.
not 9.3. Oh, they
No,
lowered
they
it.
lowered
Okay,
it. Yeah.
that's good. Good. All right, cool. And then nice. And then some of the contraindications of bisphosphonates. If you have like esophageal disease, like Barrett's, like esophagitis, or like
Mm-hmm.
esophageal uh, dyskinesia, or anything like that. If you have an allergy, if you can't stand up straight, like these things. And dosing, yeah, I think just know like two of them, so you can say it. And like know some of the other options too,
Yeah,
like even if you
the
don't
ligand,
prescribe them.
rank ligand.
Yeah, yeah, rank ligand and these things. Yeah, and there's the para thyroid
Yeah.
hormone recombinant and things like
Yeah,
that.
yeah,
So just
yeah.
like
Uh-huh.
read about it. Yeah, so you don't, so we'd like if they want to know more, you can tell them. All right.
I can tell them that I don't know.
Not every time, not every time. All right. Only a few times in the exam. And then
Uh-huh.
and the chlamydia, yeah, I think the rescreen was pretty good. What did I ask you about the chlamydia? I don't even remember.
Rescreen
Uh,
and retesting. Retest
yeah,
versus rescreen.
the test of cure.
Yeah,
Yeah.
test of
All
cure,
right.
right?
And then abnormal uterine bleeding. You can say it's abnormal bleeding from the uterus that is abnormal in frequency, duration, regularity, or volume. That that like that like encompasses like a lot of the abnormalities with
Mm-hmm.
abnormal uterine bleeding, and you can say that uh, it's more than 80 cc's of blah 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 of like menstrual blood loss, and what do you call it? And uh, the symptoms are not like you said. It's not very. There's like poor correlation between the symptoms and like the actual like the perception of the symptoms, and how like
The amount.
and like how yeah, and like how like heavy the bleeding is actually. Let me find the slide. There was a slide here that said, but I think it's around 30% of patients, no more. Wait, let me find it. Just a sec. There was something I was looking at here. Assessing. Oh no. Okay. Yep. Uh, and like in the definition of like abnormal uterine bleeding too, you can say in the absence of like pregnancy. That's really important.
Mm-hmm.
So like bleeding that is abnormal and blah blah blah. Duration, frequency, volume, or regularity in the absence of pregnancy. That's a nice
Yeah, yeah, yeah.
definition.
That's true.
Yeah, yeah, and then assessing. Just a sec here. Trying to find that slide with the correlation. What is normal? Yeah, how women perceive. Okay, so the correlation is poor. One third of women with normal blood loss consider their menses to be heavy or
Abnormal.
excessive.
Uh-huh.
And then 40% of women with documented more than like 80 cc's of like blood loss describe their menses as light or moderate. Okay, so there's very poor
Light.
correlation. Yeah, seriously.
Is that
All
40% you
right,
said?
40%. Yeah, a
Wow.
third and
Okay.
40%. And then yeah, I think with the treatment options, really good. And then what else? Anything else here? No, I think we didn't speak about. And the FIGO classification, I think you were trying to say like intramural. So there's
Oh
sub
yeah,
like
intramural, correct. That's
intramural,
what I'm
and
trying
then
to say.
that's important, I think, for the
Yeah,
exam to
yeah,
know the
yeah, for
FIGO,
sure.
because there's a lot of like fibroids on like everyone's case list, so they can really ask a lot about it.
Yeah.
And then what do you call it? And then there's like a type 8. Don't like forget it.
Mm-hmm.
That's the
Cervical.
one on the cervix. Yeah, the cervix, or like parasitic or something like that. Something
Mm-hmm.
in a weird location. Yeah.
Yeah.
And then what else? Secondary amenorrhea. Oh, dude, you got to read about. Yeah, you got to know your secondary amenorrhea.
Mm-hmm.
You can
Yeah.
ask you about that. And then we did recurrent yeast before, and then Bartholin's. I think you did pretty good. I was reading on the procedure and stuff. They say to do the incision proximal to like the hymenal ring, so like where you said is correct. But if you say, I do it proximal to that, like hymenal ring, it may sound more elegant.
Mm-hmm. Yeah.
And yeah, and like you leave it there for like 4 to 6 weeks. Yeah, but it usually falls out way before that. Like it's
Right.
only the longest I've seen it is like 2 weeks in someone, but then it just like
Oh
falls out. I think they pull it out, man. But anyway,
yeah, it's
uh,
uncomfortable.
it's very uncomfortable. Yeah. And then biopsy, they may like grill you a little bit. Did you write that you did like a biopsy for this lady in 17? Because she's like 60 years old.
Yeah, I did.
Oh, it's there. It's written
Yeah,
that you did.
incision and
Yeah,
drainage with
with biopsy.
biopsy.
Okay.
Uh-huh.
Yeah. Okay. Cool. Sorry, I didn't. Yeah, it's like at the end,
Uh-huh.
and then hot flashes.
Oh,
Uh,
um the what I say about
oh,
the
the
bleeding, the
branches.
no, not the
Oh, the
branches. I
bleeding
mean
is fine.
branches I can look it up later, but
Yeah,
um it's the pudendal, right?
the pudendal. Yeah, internal pudendal. Yeah,
Internal
because
pudendal. Okay.
mhm. Yeah, because I don't know where the external arises from. I think from the external iliac, but the internal. So the external iliac, the only like vessels that it gives off that we are like interested in as like gynecologists, or are the superficial like epigastric, the superficial circumflex like iliac,
Okay.
and like the inferior like epigastric. These are the three vessels that uh, we care about from the external iliac. Everything else is from the internal iliac. We
Right,
don't.
right,
Yeah,
right.
we don't. Yeah.
Yeah.
So yeah. So just not to like open a door that
Mm-hmm.
they will not close for you.
Yeah,
And then
definitely not closing.
yeah, and then the branches are a lot, but once you like have it like in a sheet of paper or something, or like on a wall somewhere, and you keep like looking at it a lot, you will like remember it. It's
Yeah,
like easy,
yeah.
but it just needs like uh,
Yeah, I
uh,
just had to review
a
that real
repetition.
quick.
Yeah, and then pelvic organ prolapse. I think your definition of the pop Q is really good. Uh, they may ask you to like, or like from my understanding is if you want to use like a pen and paper and like use the grid and like show them how you calculate it and stuff. So just practice doing that before you go to Dallas too, because they
Mm-hmm.
may
Yeah,
give you the thing and tell you, okay, show me how whatever.
yeah, they might. Cause
But
I
yeah.
do have a sacrocolpopexy on my GYN list.
Oh,
So
oh, you do. Did you do it?
no, I didn't do it, but it's
Oh,
I
yeah,
did a
yeah.
hysterectomy part.
Yeah, you did the hysterectomy. Yeah, cool. And then yeah, I think that's everything.
Cool. That was good.
But just like review the pelvic organ prolapse and the treatment options and things like that. But I think you did like you mentioned the pelvic floor physical therapy. That's really basic, and it's really important to like you always like start with that and then see how the patient does. Yeah.
Mm-hmm. Yeah. All right,
All
cool,
right,
man.
dude.
All right, go get some
Are we
food.
doing Sunday or? Yeah,
Yeah,
thanks,
yeah,
dude.
sure. We'll do Sunday.
What time did we say Sunday?
I thought we said 4, right?
Four. Oh, 4 or 3. Yeah,
3 or
four sounds
4.
good. So
Yeah.
so I'll wait. And then there's like the webinar at 5:30. So yeah,
Right.
so we'll do it for an hour and a half and then do the webinar.
Yeah, yeah,
Do you
yeah.
know if
Hmm?
Hannah's doing the webinars too, or is she just
I don't
not?
think so. Cause I
We
don't think
should tell her
she
to
have
do it,
time.
man. It's very
She
helpful.
doesn't have time.
Oh, she doesn't. She
She's
doesn't.
so busy.
Does she have kids?
She has a kid and then she's doing all these other
Yeah.
stuff. So like
Yeah, her lasers and all that.
yeah.
Yeah. Yeah. All right, dude.
All right,
Okay,
man.
man.
All
Have
right,
a good night.
yeah,
I'll speak to you later, man.
yeah.
Take care.
All right, bye.